And our next speaker is Dr. Swayman Singh. Dr. Swayman Singh joined UC Davis very recently this year. He's a new strain of cardiologists that are also trained in interventional cardiology. And a lot of the reasons why this need has emerged is also because of the higher prevalence of this patient with cardiogenic shock. So more and more, we have just to be vested in the, and proficient in the being able to acutely intervene and support these patients. Dr. Singh joined us. He did his heart failure and transplant fellowship in Mayo Clinic. Then he did interventional cardiology, and we have been fortunate that he decided to come to California and join us. Thank you, Dr. Singh.
Hello. Thank you, everybody. Thank you so much for taking the time out on a Saturday. What a great turnout. Thank you, Dr. Kardaras, the committee. I mean, you guys did an amazing job. I mean, I was lucky enough to see the work that you did to make this happen, such an important talk. So thank you for all the time that you put, Dr. Kardaras, in making this happen. How do I just press the green to go forward? Or you guys do it kind of automatically?
No, there is
the green, right?
And then there is one that...
Okay, good. Perfect. All right. So my name is Swayman Singh. I'm one of the heart failure docs here, and lucky to be here. Great facility, so many great seniors, and it's been a good time. So my talk for this this really good session is initial evaluation and classification, right, for cardiogenic shock. And you say, well, you know, if you think about your patients that come to the ED, right, what happens? Okay, you got to sign in, you got to check in. All right, we'll get an EKG. Okay, guys, let's get an X-ray. Let's, you know, okay, should we call the heart failure people? Should we call this, that, internal medicine? Move on, move on, move on. 6 hours, 8 hours, 10 hours have passed. All right, we get labs. The labs don't look good. Are they real? Let's get repeat labs. Imagine, why is this important, the initial evaluation? Because if you screw up on this initial evaluation, you will cost your hospital and the system millions of dollars. Imagine you had a reversible cause for that heart failure, and we missed it because of time, something missing in, you know, the way we're supposed to do things. That patient suffers, but that means that patient's going to stay in the hospital longer, and it's going to keep coming back up because how we think heart failure does. So to me, I think the initial evaluation, how you label this patient, how you treat this patient, how you, the stuff that you put on them, non-ischemic cardiomyopathy, ischemic cardiomyopathy, STEMI, whatever, non-STEMI, whatever you put on that first note, we have a tendency to grab onto that and go with it. So I think the initial evaluation in a shock patient, how we do it, it's very important. And classifying shock, this is kind of like a newer term. Before we said shock, you know, hey, this patient has cardiogenic shock, and we treat cardiogenic shock one way. If I remember going back to medical school and residency even, the way we looked at shock, cardiogenic shock, okay, patient has cardiogenic shock, this is how a cardiogenic shock patient presents, and this is how we treat a cardiogenic. There's no like 2 cardiogenic shocks. There's no 3 types of cardiogenic, it's 1 type of cardiogenic shock. That's the way I remember. Maybe it was different, I don't know, maybe I forgot, I'm not sure, but most of my references will come from this ACC consensus document that Dr. Kardaras had sent me a few months back. I was thankful for him for sending me that. It's a great article. I would suggest, like, it's literally like maybe a 2-hour read, I think, at most. But it really breaks it down, the importance of some of the things that we are talking about today. So this is I really wanted to talk about other things, but I wanted to keep my talk very relevant onto this document. So I'm kind of hoping that I don't go off tangent and talk about things that were not discussed in this document. So, you know, I love AI, and you guys love AI too, right? We go Google and we say, hey, you know, my patient, what does it look like, AI? So I said, AI, you know, how do I treat cancer? And AI gave me a really good answer. And AI said, you know, you type it, you stage it, you genetic it, and you know, every tumor is different. I was like, wow, this could be our heart failure. You know, what if we type it, stage it, maybe genetic it, and like treat heart failure differently depending on the phenotype? Then I said, how do you treat cardiogenic shock? It wasn't that bad, honestly. I was hoping that this would be a slide where I say, we went off, crazy, but actually I did a good job. It said, if you have cardiogenic shock, and what you're going to see is inadequate perfusion. So, the heart is not working, and heart is likely the cause of the underlying problem. And you're going to have organ dysfunction, and you're going to manage it in a team-based. So I think this is where we break it down. It's like, it says structured. How many hospitals of you guys, wherever you're coming from, say, hey, I have a structure. And the structure is same for the ED guy, for the cardiology guy, the internal medicine guy, the nurse, and everybody understands the structure. We have a structure. This is the way we do things. If a patient is presenting with these symptoms, we have a structure to identify him and get him all to the next, whatever. So that's number one. Then it says team-based. How many hospitals have teams? Where we can, imagine me, like, first year, going to see a patient, oh my God, is this cardiogenic shock or is this something else? What if I had an opportunity to just turn on my phone and talk to Dr. Kadaris, Dr. Bong, and some of our nurse practitioners who've been here for so long and so experienced, and we all get on a phone call and say, hey, this patient looks sick. And why? Say, why do we have to spend so much money doing this? Because of my first slide. If you don't do it the right way, you will cost the hospital so much money, because that patient will, and I will talk about it later, his stay will be longer and he will keep coming back up because of this initial evaluation. So team-based and hemodynamically guided. So a lot of great things here. So if you go to AI will tell us a lot of good things. So what are my learning objectives for this talk? So diagnosing cardiogenic shock, that's the first thing, right? How can we go to our medical student and our very junior people and say, hey, this is how you kind of look at cardiogenic shock, and this is how you diagnose it, kind of similar to the way I would. And then stage it, and then phenotype it. It's just three things that I'm going to be talking about. That's it. Diagnosing, staging, and phenotyping, and maybe why it's important. So this was brought to us in 1992. And I think this is probably a very important slide on what happens in the neurohormonal hypothesis. And this is not new. This is 2025, 25 plus 8 is like 33. So 33 years ago, we figured out how possibly shock does and how shock affects our body. So what they said back then was, you're going to have a primary insult. It might be a heart attack. It might be you didn't take your medications, you took too much salt, too much water, something. You did something to yourself, or somebody did something to you that affected your heart in some way that affected the LV, the RV, or both ventricles. And what's going to happen if your heart gets affected? Your heart is not going to be able to pump, so what's going to happen? Your cardiac output is going to drop, your stroke volume is going to drop, and because your cardiac output drops, usually your blood pressure will drop, right? Volume is a big thing that's kind of gaining your blood pressure, so your blood pressure is going to drop. What's going to happen? Your body has this response. If I'm not getting what I need, I'm going to activate the sympathetic response. And you would say, how long does that take? Could take less than an hour. So from an insult, imagine a STEMI, imagine, acute infection going on, you drank too much water, whiskey, cocaine, something. Within an hour, you're going to have all this. The blood pressure is going to drop, the cardiac output is dropping. So I'm not saying it's going to happen in one day, within a day, but it could happen as fast as a minute to an hour to a day. So you're going to see all this. So so imagine, and the reason this slide is important, because the way we look at cardiogenic shock changes on where on this curve the patient is at the time you saw them. So if you saw them at the first, when I have the red, their blood pressure might be okay if they're in the first two. By you get to the third, we see a decrease in blood pressure. Then you got the baroreceptors. What's going to happen? The sympathetic response happens. You're going to have hypertension possibly. You're going to have or normal blood pressure possibly. Your heart rate will be high. You're vasoconstricting, your vessels in the belly, everywhere, and your volume in the intravascular space is going to be high. And this is happening. So imagine you're in the ED and your blood pressure has or your patient has normal blood pressure. You're going to say, oh, my shock definition said your systolic blood pressure was less than 90. This patient will not meet that. but it's in shock. And what happens, your heart obviously now is struggling to pump against, which was, there was a hit. Your body did the sympathetic response, increased the blood pressure, increased the afterload, increased the preload, increased the work of the heart by actually making the heart rate go up. And what's going to happen? Inflammation, vasodilation, multi-organ failure. And that's how shock goes. And it doesn't wait for that 10, 12-hour, 14-hour thing. This is happening within 30 minutes, 1 hour, within a day, way sooner than a day. So this is where we are now. We have to define shock. If you guys remember a few years ago, the way shock was defined because of most of the clinical studies was, hey, the blood pressure is below 90, drop of more than 30 within 30 minutes, that's gone. The blood pressure is gone. I don't think you should be looking at that. And why? Because of my last slide. So what should you be looking at? You're looking at the heart. Hey, the heart, there's something not right. There's something seems that there's a hit on the heart. And because of that, it seems the perfusion of the body is not appropriate. And you're having some type of end organ hyperperfusion, basically end organ injury. Your heart is not pumping to the body, and because of that, your body is suffering. That's cardiogenic shock. And that's how I define it. And how do you get there? How do you, basically get to that point where I'm able to confidently say that the heart took a hit and then organs are, not functioning well or hyperperfusing is how you're going to define shock. And you have to get there. And this document goes into that. So what are the most important things that we need to do? I mean, look at top, 0, 30, 60, 90. So half of my document is 90 minutes. So now go back to your ED and say, where are we looking at this golden hour, golden day, and how are we, then it's initial evaluation. How do I do initial evaluation? We all know heart failure. Heart failure presents like what? You're not able to send the blood to your body, so you have symptoms, altered mental status, you have organ perfusion, but then also congestion, blood is backing up into the lungs, so I'm having shortness of breath, I'm having dyspnea upon exertion, I'm having orthopnea, PND. In shock, it's just next level. So imagine your symptoms that you see for heart failure, now just probably a next level up. So those are the initial evaluation symptoms you're looking for. So some are physical exam. The other things we look for, urine. And why is it many? It's not one. Because, imagine your patient has CKD, has renal failure. So you don't want to, and I have some favorites. You want to pick some favorites. Hey, these are the ones like golden, like lactate. Things that might be your favorite. But you want to have multiple. Because a patient might have comorbidities, many of our patients do, that kind of sometimes muddy the water. So you want to have on your initial evaluation a few things that you look for. Are they cold? Are they warm? They might have PAD that might be causing that cold or warm. So look for other things, congestion, altered mental status, urine. The big thing is, whatever you're looking at an initial evaluation and you're documenting, you're going to go back and reevaluate those things within 90 minutes or 3 hours. That's the most important thing. So if you guys know, how many people look at lactate for your heart failure patients? How many people trend that lactate in 3 hours to say if that lactate is getting better? Yes, because studies show the lactate at initial evaluation is bad, but what's even worse is your lactate not improving. And what's even worse is your lactate not improving and you're saying, oh no, we'll give it 3 more hours for that therapy. So I think that's the mindset is we have to get to these patients fast, identify them fast, and if we're not able to, it's going to hurt our system. One of the big things I want to focus on is if you do bottom, in the 90 minutes, there's a right heart cath. How many hospitals have the capacity to do a 90-minute right heart cath on their patient? How many people even feel that it's important to do a right heart? And if it's not, then why is this here? And why I say it might be here, because our mortality has not changed in the past 15 years. So if you're thinking, oh, this is the way we did things and this is the way we're going to do things as a hospital system, then I'm sorry, in the last 15 years, we've failed. So we better find other ways, identify other ways to do better. And I'm not saying this is the way, but this is what the experts are saying. from data that, hey, when you take your sick patients to the cath lab, you do a right heart cath in a safe environment, it actually changes mortality. It changes outcomes. And for me, if I'm putting an MCS device in a patient, if I'm thinking about dobutamine, milrinone, something that can actually kill the patient, I actually want to make sure that I have a right heart cath. I want to know what I'm treating and how bad it is. And number two, trend that. Whatever am I doing, is it actually making a difference? So I think this is very important. And looking at it, and you know what? We have done a great job in that number two, the left heart cath. I mean, amazing. Amount of focus that we have put on these patients, door to balloon, STEMI, and how great the American system is leading the world in STEMI care, it's amazing. And how much our hospital actually yes, we gotta get this. But feel that our shock patients are neglected. But if we start realizing that these patients costing our system so much money, and we might not be doing a great job, we might start getting that golden hour. But it starts with us. It starts with you guys, the heart failure team, right? If we treat our patients with that respect, the other people will bounce on. But it starts with you guys. You have to go back to your system and say, hey, I'm going to follow these SKY guidelines. And these are the things, suspect. So the first thing it starts with, I think I have 4 minutes if I'm not wrong. This is the clock, not for timer. So it always starts with suspect. You have to suspect. And when you suspect, there's so many things, how you can go about, whether it's symptoms. We talked about the heart failure symptoms, the urine, from head to toe. Everything is hyperperfused, so pick your best organ to go and judge. And this is there in that document. I'm not going to go over each detail. You guys know this. You guys do this every day. This is the big thing. So after you identify shock, the big thing is putting them in a column. Why? Why do I put this in a column? Because this column dictates their mortality. So if you identify and you tell your team, hey, this patient's SKY shade C or D, hey man, you better look closely. We got to follow up this patient Q3 hours. We got to look at that lactate. And so how do they do it? So, A, shock, they put in SKY stages A, at risk. B, blood pressure is a little low, maybe tachycardic, but perfusing okay. SKY stage C, perfusion is now the issue. D, it's getting worse. E, you missed the ball. And why this is important for multiple reasons. Number one, they think, or from registry data, what we've seen is most people will move on to the SKY stages within 24 hours. After that, they stay in their place. Hear that again. If somebody's going to move from A to B, B to C, C to D, C to D, it's going to happen within 24 hours. Most of that movement, almost close to 90% of the movement happens within 24 hours. So if you don't have a golden hour, golden day at your program, your patients are moving from A to E, and you don't even know it. You're costing your hospital system millions of dollars, and you don't even know it. Studies have shown if your patient has hypoperfusion and hypotension, mortality is high. If they have just hypoperfusion and, again, hypotension, mortality high. Just hypotension, without hypoperfusion, just hypotension, mortality is less. So a lot of the stuff that's on here is dictated by what we've seen in our registry data from our studies. And again, right heart cath is there. And it says, and I'm going to read it to you, if invasive hemodynamics performed, strongly recommended. Strongly recommended. So we diagnose, we stage them, and I hope I'm convincing you that diagnosing them early is important. Putting them at a stage, a SKY stage is important because it's going to identify how strongly, not just me, but everybody around me, how seriously they're going to take this patient. The next thing is phenotype. As the last speaker talked about very nicely, I'm not going to go into that detail, but this is, I think, what's been stopping us from decreasing that mortality of our heart failure patients, shock patients. It's this part. We treated shock as shock. In cancer, they realized you can't treat brain cancer the way you treat prostate cancer or breast cancer. But we've been doing it all along. Doesn't matter if you're RV shock, LV shock, BIV shock, we're gonna do the same thing. And then we fail. PAPI was low, but we did this. Because we didn't have it in that system. We had this, but we did this. So I think the most important thing where we're getting at is phenotyping. Why are certain patients living? And why is this important? Studies have shown patients with AMI shock are different from non-AMI shock. They present differently. Their hospital stays are differently. If one lives till discharge, their mortality changes. So between the two types, even just the AMI and the non-AMI shock, there's big differences. So I think phenotyping is our big next thing that we're getting at. I have 10 seconds, Swan-Ganz catheter, IFLE, from the ESCAPE trial has been put down, shouldn't have. This is why we have fell behind in our shock treatments in the last 15 years because we've gone away from the Swan-Ganz. It's not a scary catheter, we can all do it. Thank you so much. And you know, the last slide is basically, hey, we just got to do a better job. We know what we're dealing with. We know this is costing millions of dollars to our programs, but I think, thank you so much again for coming on Saturday. I think this is the start that, hey, we realize this is a problem we're going to deal with. Thank you, Dr. Kadaris, for allowing me to speak.